Let's go over the warm-up review. First question. A farmer suffering from organophosphate poisoning continues to have significant symptoms despite administration of atropine. What additional drug should this patient receive? So you should give pralidoxime, which is a drug that regenerates acetylcholinesterase. Next, which enzymes are involved in the catabolism of norepinephrine? So the two enzymes are catechol O-methyltransferase, or COMT, and monoamine oxidase, or MAO. And the last question, what are the various clinical applications of atropine? So we use atropine to treat bradycardia and some types of AV node block in code situations. Anesthesiologists use atropine to decrease airway secretions. It can be used as eye drops to dilate the pupils and paralyze the ciliary muscles for ophthalmologic procedures. And we mentioned that it's used to treat organophosphate poisoning. So that's it for the warm-up, so let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on cardiac output. You better put on your math hats today because today we're talking about equations and looking at graphs and stuff like that. Wait a minute. This isn't my math hat. This is my role-playing. Hey, let's talk about cardiac output. So first, what is cardiac output? Well, cardiac output is the volume of blood that is pumped out of the heart in 1 minute. So the equation for cardiac output is actually quite simple. Cardiac output is equal to the stroke volume times your heart rate. Now, stroke volume is exactly what it sounds like. It's the volume of blood pumped out of the heart with each heartbeat. And of course, heart rate is measured in beats per minute. So again, we get the amount of blood pumped out in 1 minute. Pretty easy, right? Now, through the magic of algebra, we can rearrange this equation and discover that stroke volume is equal to the cardiac output divided by the heart rate. And another way to calculate the stroke volume is to know the difference between the end diastolic volume and the end systolic volume. It's all still pretty easy stuff. Now that's looking at the volume of the blood of the heart when it's at its fullest and then subtracting out the amount of blood that is left in the ventricle after the heart pumps. So the difference is the amount of blood that is ejected from the heart. Now the next equation is not quite so easy. It's called the Fick principle, or sometimes referred to as the Fick equation. And you definitely need to know the Fick principle here. So the Fick principle allows you to ascertain the cardiac output by using the rate of oxygen consumption and the difference between the arterial and the venous O2 content. So cardiac output equals the rate of oxygen consumption divided by the arterial O2 content minus the venous O2 content. Now you may very well get a question on your test that asks you to calculate one of those values given a certain set of information. Now the next topic is the mean arterial pressure. The mean arterial pressure is the average arterial pressure during a single cardiac cycle. Now mean arterial pressure commonly is going to be abbreviated as P, and it's going to be equal to cardiac output times total peripheral resistance. So if you break it down a bit, the MAP, or the mean arterial pressure, is how much blood you get out of the heart in 1 minute times the resistance in the system. So cardiac output, sometimes referred to or abbreviated as Q, and then resistance is commonly abbreviated as R. So when you take the equation all together, that makes the equation easy to remember. P equals Q times R, or just remember PQR. Now, mean arterial pressure can be approximated using another equation as well. This only works with normal resting heart rates though. So the mean arterial pressure is 2/3 of the diastolic plus 1/3 of the systolic pressure. Moving along, pulse pressure. Pulse pressure is systolic pressure minus your diastolic pressure. So it's basically the pressure involved in the pulsatile wave. Again, it's the difference between the systolic and the diastolic, and it's proportional to the stroke volume. The higher the stroke volume, the more the pulse pressure. Now let's cover the effect of certain things on cardiac output. So first, let's talk about preload and afterload. So preload is the pressure at the end of diastole. So when the ventricles are at their fullest right before contraction, think of that as your preload time period. And where does your diastolic volume of your heart come from? Well, it comes from your arterial volume, from your atriums. So in order to fill up the ventricle, it has to come from the atrium first. So atrial pressure is another surrogate for preload as well. So again, preload is ventricular end diastolic pressure, roughly equal to that atrial pressure, which if you take it one more step out, it's roughly equal to the central venous pressure, or the amount of blood that's returning to the heart. So what are some examples of how the preload can change? Well, preload increases with exercise slightly, and the reason for this is because your muscles are contracting, they're pushing more blood back up to the heart. That increases the preload. And by increasing your preload at the beginning of exercise, you increase your stroke volume. Cardiac output increases initially in exercise because that stroke volume increases. Now, preload is also going to increase with increased blood volume. So if you maybe overtransfuse a patient or if you overhydrate a patient, that's going to increase their preload. Pregnancy has a very high preload as well. Women have an increased blood volume during pregnancy. Next, let's talk about afterload. So afterload is approximated by mean arterial pressure, which, as we just said, is cardiac output times peripheral resistance. But what I want you to equate afterload with, maybe more simply, is just peripheral resistance. So how much pressure is pushing back against the heart? Preload is how much blood is coming back to the heart through the venous system. Afterload is how much pressure is pressing back against the heart. Now, if you see mean arterial pressure or total peripheral resistance, sometimes abbreviated by TPR, these again, all measures of afterload. Now, there are a couple of prototypical drugs that decrease the preload and the afterload. First, we have venodilators. So your nitrates, like nitroglycerin, decrease preload. Nitroglycerin venodilates the veins. Now, by dilating the veins, you're going to pool blood and fluid. You're going to pool your venous fluid in your veins instead of having it return to the heart, so you're decreasing the preload. Now, your vasodilators, think of something like hydralazine. They're going to decrease afterload. So hydralazine works mainly at the arteries, and by expanding those arteries, you decrease the back pressure on the aorta as well. Okay, so now we know the equations and some of the definitions. Let's look and see what affects our cardiac output again. Definitely a very high yield 4 to 5 star topic. Again, to review, cardiac output is how much blood the heart ejects in a minute, or the stroke volume times the heart rate. So how does exercise affect cardiac output? We mentioned this before. It makes sense that it would increase. During exercise, cardiac output increases initially as a result of increased stroke volume. Remember, the muscles are contracting, more and more is getting back to the heart, meaning blood. And during sustained exercise, the cardiac output is then maintained primarily due to increased heart rate. Now, does that mean that as you increase heart rate, the cardiac output continues to increase? Well, the answer is no. If the heart rate is too high, the diastolic filling is incomplete. You're not allowing enough time for the ventricles to fill up because they're just contracting too quickly. So each heart contraction is pushing out less than ideal volume. So your cardiac output in that situation actually goes down if your heart rate is too high. And that's why a highly elevated heart rate, like with atrial fibrillation or ventricular tachycardia, can cause a decrease in cardiac output, even though the heart rate is around 150 or even above. Next, let's talk a little bit more about stroke volume. So contractility is directly related to stroke volume. The harder the heart pumps, the more blood the heart is going to push out. And the reverse is true. If you contract less forcibly, then the stroke volume goes down. So what increases contractility? Well, contractility and stroke volume increase with catecholamines. So which adrenergic receptor stimulates the heart? Well, those are going to be those beta-1 receptors. They're going to be the major receptors on the heart. So how do the beta-1 receptors do this? Well, beta-1 receptors, when stimulated, will increase intracellular cyclic AMP, which will then result in that increased muscle contraction. Okay, so what decreases contractility? Well, it's just the reverse of what increases contractility. So beta-1 blockade. So when we give beta blockers, they decrease contractility. A heart failure decreases contractility. If there's heart muscle damage, this is going to decrease that contractility. Now, acidosis in and of itself can decrease contractility, as does hypoxia and hypercapnia. Now, the non-dihydropyridine calcium channel blockers, like verapamil, will decrease contractility as well, maybe not as much as some of the other drugs. The other calcium channel blockers are the dihydropyridine calcium channel blockers. They work primarily on the blood vessels, but the non-dihydropyridines, like verapamil, again, going to work primarily at the heart. So now back to stroke volume. What happens to stroke volume when you increase afterload? Well, if you have a lot of back pressure from the aorta and the rest of the body, it's going to be harder for the ventricles to push out a lot of blood against that back pressure, again, from the aorta. So increasing the afterload is going to decrease your stroke volume and thus the cardiac output. Now, how does increasing preload affect stroke volume? Well, preload is another way of thinking of diastolic filling volume. So it's the amount of blood you're pushing into your heart, into the ventricles. So if you push more blood into your heart, you're going to expel more blood from your heart in general. Now, the stroke volume is increased when preload is increased. So to recap, to increase the stroke volume, you can increase contractility, decreased afterload, or increased preload. All right, so now let's go over ejection fraction. How is it different from stroke volume? This can be confusing for some folks. So ejection fraction is what your heart can pump out divided by what your heart can hold with each beat. So it's a percentage or fraction. A normal ejection fraction is about 55 to maybe 70%. Now the stroke volume is how much the heart can pump out per beat. So it's a volume, not a percentage. The ejection fraction is an index of ventricular contractility. So as your ejection fraction goes up, that generally means that you've improved or increased your contractility. Now, one of the most common findings with systolic congestive heart failure is a decrease in that ejection fraction. Now, as the heart decreases its ability to provide a strong coordinated contraction, the ejection fraction then thus goes down. All right, so now let's look at some calcium physiology in the heart muscle.
All right, everyone, welcome to another Lewis Notes, and we're talking about muscle cells today, and we've got this beautiful picture that I just wrote for you. You might want to take a minute to either just at least familiarize yourself with it or even write it yourself to get an idea of how calcium affects the myocyte. So we have a myocyte that's going to want to contract because that's going to be how your heart is going to function, and it's all about calcium. So let's go through some of these ways in which calcium either gets in or out of the cell. And before we do that, so we talked about in the lecture what causes the calcium to increase in a cell. Well, the big major change is that the sarcoplasmic reticulum releases a whole bunch of calcium, and then that's going to lead to muscle contraction. But we have to get to the point where that sarcoplasmic reticulum gets stimulated. And how do we stimulate a sarcoplasmic reticulum? With even more calcium. So calcium begets calcium in this situation. So let's go through sort of these different pathways in which we see all of our different electrolytes moving all over the place. So first, if we look over here we have a sodium-potassium ATPase. And you'll notice there's no calcium involved there. So why am I even talking about this? Well, you have to have different gradients of potassium and sodium in order to maintain a certain gradient. And then that gradient is then going to help us move other types of things like calcium in and out of the cell. So in this case, we're moving sodium out, and then we have an extracellular sodium concentration, and we have an intracellular sodium concentration. So how's that going to affect other things? Well, we've got this other thing called this sodium-calcium exchanger. So in this case, we're actually moving calcium out of the cell as we're moving sodium into the cell. So you can see how this sodium gradient is still going to be very important on whether or not we can move calcium out of the cell. And then our third thing here is what we call a voltage-gated calcium channel. And this thing is just a big old gap that allows calcium into the cell. And it can either open or close depending on what type of voltage is going on in the cell. So that's one way we're going to get calcium in. And then we've got this other way in which we're going to leave calcium getting out with this other exchanger.
All right, so as soon as this calcium level right here gets high enough, that's actually going to kind of move over here to the sarcoplasmic reticulum. Now there's just another random transporter here that we're really not going to talk about, so don't worry about that one. So this calcium, it's going to increase, or it's going to at least stimulate the desire for that sarcoplasmic reticulum to take all of its calcium that's got all stored up over time, and then it's going to shoot it out of the sarcoplasmic reticulum into the cell cytoplasm, thereby triggering muscle contraction.
So why is any of this important? Well, what's important is that we have a lot of drugs that will affect on some of these transporters here. So if we look at something like this ATPase, this sodium potassium ATPase, digoxin will shut this down. And that will effectively change the gradient of sodium that's in and outside the cell. So if we shut this down, then we're effectively going to be decreasing our extracellular sodium. And if we don't have a lot of sodium out here, there's not going to be much of a gradient to want sodium to come back in. So that's going to shut down this thing right here, which is going to effectively increase our overall calcium. So what does digoxin do? Remember, it increases contractility, and that's because it's maintaining more of this calcium gradient on the inside. So what if we wanted to decrease contractility? Well, we could use a drug that affects calcium channels. Remember how we were talking about verapamil? Well, what if we shut this thing off? Well, if we shut this thing off, then we're going to decrease the amount of calcium again, the exact opposite of what we were doing essentially with our digoxin. So we're going to decrease this calcium that's right here, and therefore you're going to stimulate the sarcoplasmic reticulum even less. So you don't necessarily need to know all the ins and outs of everything on here, But I would, have a rough idea of where these are going. And then when subsequent lectures come up on some of these drugs specifically, you'll know, it's all about the calcium that's changing the effects of this on the heart and the myocytes themselves.
Okay, so now we're going to take those concepts and put them on a curve to help us understand them a little bit better.
Welcome to the Starling curves. Sometimes curves and graphs can be a little intimidating, but really, if we'll break this down, we'll be able to figure this out pretty quickly. So this is a graph on the y-axis. We have cardiac output. You could also just say stroke volume, but I'll probably refer to it as cardiac output most of the time. And then on the x-axis, we have ventricular end diastolic volume, another way of saying preload. So as we're increasing preload going to the right, then most of the time we're going to see an increase in cardiac output. So you're giving the heart more blood and it's going to want to pump that blood out. But we do have some scenarios where that's going to change, and you need to know the changes of these curves and how they go. So look in the middle here. So if you look at our normal right here, you see that it's just kind of following along as you increase in preload, you're increasing your overall cardiac output. Now you notice that it kind of flattens out there. So there does come a part where you can increase the preload only so far, and then you start getting diminishing results. This is not a straight line by any means. So you see that does end up running out of room at some point. Now, what happens if we exercise? So if we're looking at this one right here, we're seeing that for every given preload, we have an increased cardiac output. So one reason why this is being shifted up or to the left is another way of thinking about it, is that we're increasing contractility. So as we're increasing contractility, for whatever preload is going into that ventricle, it's squeezing it even harder. Therefore, we're getting more and more cardiac output, or even more blood going into the rest of the body. So what happens if you have a disease state? What if you decrease contractility? Well, you're getting a shift of this curve. What if we have CHF? We're getting a shift of the curve to the right and down. So no matter how much preload we're giving to this person, we're not getting near the cardiac output. We do not have the heart muscle to squeeze out that extra blood and do anything. So you'll notice that even the curve is even flatter here. So instead of even our usual normal curve we see here, this one's going down. It looks even limp. What's even more important here to know is that there was a diminishing return on the normal and the exercise, but it never went back to negative. You'll notice that about right here, you're seeing that as we're increasing the preload, we're actually getting decreased cardiac output. So this is sort of what we call the fluid overload status. So CHF patients will often have episodes where they get too much fluids on board. They start getting pulmonary edema. They're getting too much afterload. They're not doing well at all. Therefore, their cardiac output even goes down. So that's another scenario that you need to realize, is that CHF patients can be very susceptible to that fluid overload state. So what if we wanted to treat someone with CHF? How would we make this movement from CHF up to a CHF plus treatment into a better scenario? Well, you could use something like digoxin. So if you use digoxin here, potentially you're increasing contractility, and by increasing that contractility, you're going to improve that overall cardiac output for every preload that you see there.
So the next topic is going to be resistance, pressure, and flow. And actually, I wouldn't spend a lot of time trying to memorize any new equations regarding this. What you do need to know is that as you increase viscosity of blood, you're going to increase resistance, which actually makes a lot of sense because the thicker the blood, the less it flows. So viscosity will increase in diseases like polycythemia. Hyperproteinemic states like multiple myeloma. You have a lot of antibodies around that increases viscosity, which is going to increase your resistance. Hereditary spherocytosis is a state of high viscosity because those big red blood cells are circular instead of biconcave. They're not very flexible, so that increases viscosity, which is going to increase resistance. All right, so now we're going to move on to cardiac and vascular function curves. These function curves are like Starling curves, but just a little bit different. Again, cardiac output is on the y-axis, and on the x-axis we have the right atrial pressure, which we've said before is the preload, which again is the same thing as your end diastolic ventricular pressure. So this is, again, just kind of a different way of drawing out the Starling curve. So in the middle of our curve here we have our baseline. Again, we know this. If you increase your preload, then you're going to increase your cardiac output. But then there is going to be a flattening of that curve eventually. The heart can only hold so much, it can only pump out so much blood. Now what happens if you decrease contractility? We've already gone through this, but this looks a little bit different. What's going to shift that curve over to the right and down? So as we covered before, a heart failure is going to decrease contractility and show that shift. Now what else can make our curve shift to the right and overall decrease cardiac output? Well, increasing afterload, too much pressure going back on the heart, that's going to decrease cardiac output for every given preload. Now, what's going to shift our curve up and to the left? Well, we said exercise can do that. Drugs like digoxin can do that. So again, nothing new here. Now, the one other thing that I want you to look at here is the venous return. So these are the lines that tend to go down as you go across the graph here. Now, where these lines intersect is where the cardiac output is equal to the venous return. This is what the body wants. The amount of blood leaving the heart is the same as the amount of blood the venous system is returning to the heart. Now, because the cardiovascular system is a closed loop, this is really what you want. You want this all to be equal, for if you start to have a problem here, you're going to accumulate blood in either the systemic or the pulmonary circulations, and that's when you start to see things like systemic or pulmonary edema. Now, you can also see that if you lose a lot of blood, say through hemorrhage, then that's going to alter your ability to provide enough preload, and again, you see a decrease in cardiac output. All right, so these graphs aren't all that complicated if you know the basic principles, and then you can go through these. All right, so now it's time for that end of session quiz. Try to answer those questions yourself, and then we'll go through those together. What is the pulse pressure in a patient with a systolic blood pressure of 150 and a MAP of 90? Well, the equation for mean arterial pressure, or MAP, is 1/3 of the systolic blood pressure plus 2/3 of the diastolic pressure. Now, you know the MAP and the systolic blood pressure from the question, so you kind of plug those into the equation. So the mean arterial pressure is 90, and then 1/3 of 150 is 50. So we need to calculate the 2/3 of the diastolic blood pressure in that equation. So you need to figure out the diastolic pressure first, so you can plug that into the formula for pulse pressure, which was our ultimate goal here. Now, I won't go through all the math here, but if you do the algebra, you end up with a diastolic blood pressure of 60. Then you know the diastolic blood pressure, so you can plug that into the formula for pulse pressure, which is the systolic blood pressure minus the diastolic blood pressure. Again, the systolic blood pressure 150, the diastolic pressure is 60. Subtract that, you get your answer, which is 90. Next question, what is the basic equation for cardiac output? Well, cardiac output is equal to stroke volume times heart rate. Next, what is the Fick principle? Well, cardiac output is going to be equal to the rate of oxygen consumption divided by the difference between your arterial and venous O2 content. Next, how can the myocardial oxygen demand be decreased in circumstances where the heart is ischemic? So you can decrease afterload, and you decrease afterload by reducing systemic blood pressure. You also can do this by decreasing contractility, you can decrease heart rate, and you can decrease preload. Next question, what can make the stroke volume increase for a given preload? So keep preload the same. Well, you can get this first by increasing contractility. So how are we going to increase contractility? Well, it can be accomplished by sympathetic stimulation. You could give an inotropic drug like catecholamines or digoxin. You can increase intracellular calcium, or you can decrease extracellular sodium, and that again is what digoxin does. Then another way to increase stroke volume is to decrease afterload. Drugs like hydralazine or maybe an ACE inhibitor. All right, next question. What is the cardiac ejection fraction? So that ejection fraction is an index of ventricular contractility, and it's going to be equal to the stroke volume divided by the end diastolic volume. So it's the percentage of that blood that the heart can eject from the heart with any given contraction. All right, guys, that brings us to the end of the video. I hope you learned something. I'll see you next time.